Alright, today we're going to be talking about the National Patient Safety Goal, about alarm safety, specifically alarm fatigue in the ICUs. So, biggest thing is alarm fatigue is a growing problem. It's basically a way to describe potential and actual errors that are created by missing clinical signs due to frequent and unnecessary alarms from our physiological monitors, like the PVC rate on a particularly paced patient, a decreased SpO2 with a poor waveform. So we're just going to go over basically why this is a problem and how we can fix it. And we also have a case study in here just to talk about that briefly. So why is this important to us? Basically, our patient alarms cover all of our physiological systems. Sometimes they can read incorrectly, but if we miss one, then we can possibly have potential patient harm. So our main goal is to reduce the number of unnecessary alarms and by proxy, reduce the alarm fatigue. A couple of examples of potential alarm fatigue pitfalls: low volume alarms that are being missed because they get turned down. Unrealistic parameters. So if we've got somebody that's an AFib, we've got an AFib alarm going off frequently, and they're a known chronic AFib patient, then that's something we could cut out. Sometimes alarms get disabled, like our respiratory alarm sometimes gets shut off, lead to missed apnea. And sometimes, like I described, we have oversensitive alarms that are picking up on like the PVCs. So that. So I brought in a case study. This is a patient that I had at a previous hospital. It was a 65-year-old male, post-cabbage. They'd been triggering the tachycardia alarm for several hours with a normal sinus rate in the 120s. So eventually that just got ignored to the point where the patient ended up with an SpO2 of 92%. His blood pressure was decreasing, had rising PA pressures, and ended up, it was just early signs of RV failure, what eventually led to RV failure. So this patient ended up having to have a RVAD, some surgical intervention that could have possibly been prevented. So what happened? We just basically went over that. We missed potential clinical signs basically by not laying eyes on the patient. So the important thing to take away from this is that physical assessment needs to go with each and every alarm, even if it seems unnecessary. So why this happened, the alarm was not met with a physical assessment of the patient. So some ideas that I read about in a few research articles suggested that ways to fix this are to customize alarms for each patient. Like we talked about with the AFib patient, we could take that off if he's a known AFib patient, because they're basically just looking for rate control at that point. You can establish standard alarm ranges and sensitivities for the unit. So this could be specific to cardiac floors, have different things that are more important or that are more common than other areas that could be probably tightened up a little bit. Obviously, do not disable alarms of any sort, and assess each alarm for accuracy with waveforms, hemodynamics, and physically view the patient just to make sure that this alarm is inaccurate. Also, we can decrease environmental noise and stimulation just to kind of take that out of the equation. It's just being tired of hearing a lot of background noise in general can lead to alarm fatigue. First research article that I brought in was by BJ Drew and company here. This article basically explores the problems of alarm fatigue as a whole. It's a large-scale study with 461 patients over a 30-day period. Discusses the most common alarms that eventually lead to alarm fatigue. Also just interviews several staff nurses to see which alarms they feel are the most problematic. The only other study that was as close to a large system was the MIMIC-2 study in 2014. Second article basically talks about the importance of correlating a patient alarm with the physical assessment. So just making sure that we're actually treating each alarm as a real alarm instead of just silencing it as a unit. And the last article that I brought in was just it basically just went over the an actual unit that had attempted to implement some individualizing of the alarms. So it was a pulmonary floor, so they basically loosened up their SpO2 monitors so that our like chronic CO2 patients, like COPD, instead of a 90% hypoxia alarm, they would set it to 88 or 87 to see. And it did end up cutting down on the amount of unnecessary alarms, but basically the gist of the study said that they couldn't necessarily recommend it just because of its kind of a slippery slope when dicing that up from a patient safety standpoint. So there are options out there that are effective, but there's just not quite enough raw data to support that change yet, but it is still the number one recommended change is just individualizing alarms for patients. We already went over kind of the steps to alleviate alarm fatigue. I don't think there's anything new there. No. That's really about it. These are my references here. Do you have any questions?
No.
All right. That's it.